Bismillah ar-Rahman ar-Rahim. Dear colleagues and PGs, in today's session, we shall discuss update on the management of functional dyspepsia. Let's see the global prevalence of uninvestigated dyspepsia. Different studies, they report different prevalence across the world. And the red is the one where it is the most common one, and then the different colors coding. So the dyspepsia is a global problem. It affects each and every nation, each and every country. No age is bar. It can affect any age, children and middle age, young and elderly, as well as both male and females. The global prevalence of functional dyspepsia, again, the white is where there is no data. Then depending upon the prevalence, different color coding, where it is more than 20%. This is the dark blue. In Pakistan, there is no concrete data, but we see that functional dyspepsia is one of the common health problems in medicine as well as in gastroenterology practice. So I'll share one case history with you. A 38 years old female presents with a 6-month history of persistent post-meal fullness and early satiety after normal-sized meals. The symptoms are bothersome enough to interfere with daily activities and social life. She denies weight loss, vomiting, dysphagia, GI bleeding are alarming features. Her bowel habits are normal. The diagnostic workup of this case, physical examination, unremarkable. Routine labs, CBC, liver function tests, and thyroid stimulating hormone TSH within normal limits. H. pylori testing is negative via stool antigen test. Upper GI endoscopy was done and it's normal mucosa, no peptic ulcer, no malignancy, or no endoscopic evidence of gastritis. Abdominal ultrasound, again, no hepatobiliary pathology noted. So in Rome, 4 criteria fulfilled for postprandial distress syndrome, a subtype of functional dyspepsia. Now the case history number 2, a 45-year-old male presents with intermittent epigastric pain and burning sensation, often worse on empty stomach and partially relieved by food or antacids. The pain is not related to defecation and not associated with nausea, bloating, or early satiety. There are no red flag symptoms such as weight loss, anemia, or GI bleeding. On diagnostic workup, physical examination, mild epigastric tenderness, no masses or organomegaly found. Blood tests, the CBC, liver function tests, amylase, all normal. H. pylori testing is positive and it's confirmed by urea breath test. Upper GI endoscopy, normal mucosa, no peptic ulcer or malignancy. So the diagnosis based on Rome 4 criteria for epigastric pain syndrome is there. So we'll refer to the recent guidelines on dyspepsia, that is the ACG and CAG clinical guidance, management of dyspepsia, which appeared in 2017. And of course, the British Society of Gastroenterology guidelines on the management of functional dyspepsia, which were published in 2022. And of course, the recent guidelines on dyspepsia published in Journal of Gastroenterology and Hepatology, the Asia Pacific guidelines, which appeared again 2022. So let's see what's the definition of functional dyspepsia and what are its subtypes. Functional dyspepsia is defined as chronic dyspeptic symptoms without an identifiable structural cause or upper endoscopy. So it's a chronic dyspeptic symptoms, and you don't find any cause, structural cause, on upper GI endoscopy in such cases. And then this is called functional dyspepsia. The subtypes, according to the Rome 4 criteria, one is postprandial distress syndrome, when there's early satiety with post-meal fullness. And another is epigastric pain syndrome, or case history number 2, when there is epigastric pain or burning, which is unrelated to meals. And when we see the functional dyspepsia, the PDS and EPS, at times they may be discrete, but in many patients, they are overlapping. In the same patients, you see both types of symptoms in both types of conditions. So the postprandial distress syndrome and epigastric pain syndrome, they may present as in solo variety or solo problem, or even the combo. The postprandial distress syndrome, overall its prevalence is 61%. In states, USA, 59% of people have reported. Studies from Canada, 63%, from UK, 63%. So overall, it is 61%. Then epigastric pain syndrome, 18% is the overall prevalence, and in the US, 16%, in Canada, 21%, in UK, 17%. And the overlap, I saw that the overlap is good enough. In almost 1/5 of the cases, it may be an overlap. Both the postprandial distress syndrome and epigastric pain syndrome, they may be present in the same individual. What should be the diagnostic approach in such patients? Look for the red flags, and these needs immediate endoscopy. And these red flags are history of weight loss, when there's a bleeding, upper GI bleed, hematemesis or melena, when a patient present with anemia, long-term dyspepsia and anemia, or vomiting, or if the age is more dysphagia, or if the dyspepsia appears in elderly people more than 60 years. Here, what we have seen in Pakistan, especially Afghan people, age more than 50, is a red flag, and one should do the endoscopy. If age is less than 60 and there is no red flags like weight loss, bleeding, anemia, vomiting, or dysphagia, then you should do the non-invasive H. pylori testing, and if it is positive, you start this patient and you give this patient's H. pylori treatment. The contributing factors for the functional dyspepsia, these are visceral hypersensitivity. Then there is disrupted gut immune interactions. There is abnormal upper GI motor and reflux functions. Then psychological factors, genetic factors, and altered brain gut interactions. All these are the different contributing factors towards functional dyspepsia. This is not the topic of our today's discussion, but remember that because of these many factors, it's not necessary that only one factor is contributing to functional dyspepsia in any patient. It may be a combination of factors. So what are the treatment options in such cases? These include test and treat H. pylori. This is the first option. Then acid suppression therapy. Then the prokinetics, neuromodulators have got their role, and of course the psychological therapies. The test and treat H. pylori, when to go on that? It's a non-invasive testing, urea breath test and stool antigens. So always check the urea breath test or stool antigen for H. pylori, and treat with standard triple or quadruple therapy when the patient is found to be H. pylori positive. And eradication can relieve symptoms in a subset of patients. Remember, not in all patients. Reassess symptoms after eradication. So this is important. And this is the first treatment option. When you haven't done the endoscopy and endoscopy is not required, and you do the test and treat H. pylori strategies. Then the second treatment option, the acid suppression therapy, and it's not the solo option. You combine even with the option A. And this option means PPIs, first line for epigastric pain syndrome, and these may be omeprazole, esomeprazole for 4 to 8 weeks. H2 receptor agonist, alternative to PPI if PPIs are not tolerated. Then the prokinetics, another important treatment option in functional dyspepsia. It's more effective for PDS subtype, and the options include domperidone. We know it's limited by the cardiac side effects. Then etopride and metoclopramide, it's for the short term, and because they have got the CNS side effects, therefore these are used for the short term. And the procalopride off-label in some regions, but mostly we give this in the functional constipation, but people have used in the functional dyspepsia as well. Then neuromodulators, the neuromodulators therapies. They are used especially in refractory cases and where visceral hypersensitivity or central sensitization is suspected. And these include tricyclic antidepressants, the low dose amitriptyline 10 to 25 milligram at night, and SSRIs or SNRIs, mixed evidences for these, and may help in coexisting anxiety or depression. Then comes the psychological therapies. Cognitive behavioral therapy, it has got a definite role and should be tried. Then gut-directed hypnotherapy, this is another psychological therapies for functional dyspepsia. Of course, the mindfulness and stress management is equally important. The dietary and lifestyle modifications, what's their role? Avoid trigger foods like spicy, fatty, and caffeine. The patient should eat small but frequent meals. Low FODMAP diet trial in selected cases is important. Smoking cessation and stress reduction is of enormous importance and enormous help. The emerging therapies for functional dyspepsia, what are these? The ecoshiamide. It's a promising prokinetic for PDS, and now it's available in Pakistan as well. Then buspirone, 5-HT1A agonist. It improves gastric accommodation. Then ghrelin agonists, relemonorelin and ulimorilene, still under investigation, but these may be available in the future. Then herbal agents. Again, these are under investigations and may be available in the coming years. Follow-up is very important in treatment of functional dyspepsia. Reassess symptoms every 4 to 8 weeks. Consider referral to gastroenterology for persistent symptoms, or if a patient has got alarm features or significant impact on quality of life, then such patient needs thorough investigations. So, coming to the case history number 1, where we suspected the postprandial distress syndrome. The therapeutic strategy in this patient will be lifestyle modifications, small frequent meals, avoidance of fatty foods, carbonated drinks, and late night eating, weight loss if overweight. Pharmacological treatment options for this case will be prokinetics, domperidone, etopride, or ecoshamide. Of course, low-dose tricyclic antidepressants in resistant cases like amitriptyline 10 to 25 mg at night may be tried, and buspirone for impaired gastric accommodation in selected cases. And psychological support if symptoms persist. Cognitive behavioral therapy or gut-directed hypnotherapy may be considered. Best prokinetic choice will be ecoshamide 100 mg 3 times a day before meals. And it targets gastric accommodation dysfunction. And it's a key issue in functional dyspepsia PDS subtype. Does not affect dopamine receptors. So no CNS side effects are seen with this molecule. And it works better than mosapride or domperidone in PDS type functional dyspepsia. Case history number 2, where we diagnose the epigastric pain syndrome. The therapeutic strategy in this case should be H. pylori eradication, that is PPI, clarithromycin, amoxicillin for 14 days. If it is positive, acid suppression therapy, proton pump inhibitors for 4 to 8 weeks, for example, omeprazole or esomeprazole, and you may consider H2 blockers if PPI are not tolerated. Then neuromodulators, low-dose tricyclic agents, that is amitriptyline in non-responders. Non-pharmacological therapies, stress reduction techniques, dietary triggers avoidance, consider psychological therapies in chronic or refractory cases. So, dear colleagues, the key takeaways from today's discussion are functional dyspepsia is common but manageable. Tailor therapy to subtypes. Either it's a postprandial distress syndrome or epigastric pain syndrome. Combine pharmacological and lifestyle strategies. And refer if symptoms are persistent or if there are alarm features. With this, I pay thanks for your kind listening. In the coming vlogs, we shall be starting our discussion on different prokinetics. What are its types? What are its indications? What are the contraindications? How one prokinetic is superior than other. So be with me in the next vlog when we shall start our discussion on the different prokinetics. Till then, take care. Khuda Hafiz.